You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 4th, 2022. This week, Interatrial Shunt Therapy, Chronic Stress, Anxiety, and TAVR. The first topic, Shunts and Trials. Now this lead story has two messages, one small and specific, the other general and massive. The specific message here deals with the efficacy of an interatrial shunt device for patients with heart failure. The journal Lancet has published the Reduced LAP HF2 randomized controlled trial. This was a blinded, sham-controlled, multi-center trial of about 626 patients who had symptomatic heart failure, an EF of at least 40%, and a pulmonary capillary wedge pressure during exercise of at least 25 millimeters of mercury, while exceeding right atrial pressure by at least 5 millimeters of mercury. One group received a device that created a shunt in the interatrial septum. The other got a sham procedure. The primary endpoint was a hierarchical composite of outcomes: CV death or non-fatal stroke at 12 months, the rate of total heart failure events up to 24 months, and a change in KCCQ overall summary score, which is a quality of life summary. Results: there were no differences between groups in the primary composite endpoint. The investigators used something that caused a win ratio, and it was basically 1.0, complete tie, p-value 0.85. There was no difference in any of the individual components of the primary endpoint, completely non-significant. Journalist Steve Stiles has the news coverage. His second paragraph is superb. I'll quote it. Quote, hopes were high, for example, for an investigational interatrial shunt by ISAD System 2, this is called Corvia Medical, that promotes left atrial unloading. And this was after a 2017 trial, and early research suggested it improved intracardiac pressures at exercise, which is a goal of some heart failure therapies, and in selected patients with heart failure and preserved ejection fraction. So, the specific message of this story is that a device that is hemodynamically plausible and was found hopeful in small studies that measured surrogate endpoints like intracardiac pressures did not pass muster when compared against the sham control in a trial that measured important clinical outcomes. Now, the incredible value of the randomized sham-controlled trial is the most important message here. Imagine the counterfactuals. Imagine where we would be without either randomization or sham control here. First, the randomization. Let's just say we used observational data and compared a group who got this shunt versus a group that did not. Then we did some statistical adjustment, and the group who got the shunt did better. Well, if we did that, we wouldn't know if the shunt worked or if healthier patients got the procedure. That's why you need the randomization. Now, imagine a world if this device was compared to medications, say like AF ablation is, and then the shunt device did better. Well, if that was the case, we would never know if the procedure had a placebo effect or the meds had a nocebo effect, or perhaps both. And that is why when you want to show if a device is effective, the best test is a randomized trial against a sham or placebo control. Consider, my friends, if not say for the Orbita sham-controlled trial of single-vessel PCI, we would all still believe that PCI and stenting relieved angina and increased exercise time. My final comment, in Steve Stiles' story, you will read about how proponents of this device want to divert your attention to some groups that may benefit. You will read this from the PI, Dr. Sanjeev Shah. He was quoted as saying, "We hypothesize that if we enrich for responders based on screening echo and invasive exercise hemodynamics, we would find the right group, that is, patients with a HFpEF phenotype that might respond especially well to treatment with an interatrial shunt device." Do not be distracted by this. This trial showed absolutely no average effect in any of the components of the primary endpoint. No signal, none. So any subgroup analysis is purely speculative and to me most likely a spurious finding. Remember, if you do enough subgroup analysis, some are going to be positive just by chance. Now, regarding the notion of finding a population of responders, this is possible, but the onus is always on the proponents to show us a group of patients that succeed in a proper sham-controlled trial. Thus far, they haven't done that with this device. Second topic today is chronic stress. This podcast has never before covered a study from Nature Translational Psychiatry Journal. But thanks to the Portuguese edition of Medscape, I was alerted to a paper looking at the issue of chronic stress. Now, my AFib clinic is full up with these folks. CEOs, engineers, lawyers, doctors, nurses, many of whom have been divorced once or twice. They exude chronic stress. They look inflamed, not in an infectious way, in more of an angry, unsettled way. They look older than their stated age. And I've long been curious, interested in this relationship of chronic stress and health. And I say that because we've all seen older patients who look younger than their stated age. And I often ask them probing questions as to how they accomplish this. Almost always they tell you that their life is low in stress. They are married. They're living below their means. They don't have 3 houses. They have a big happy family. They usually don't smoke or don't drink that much either. So the paper was from the Yale Department of Psychiatry, the first author, Zach Harvanek, and the endpoint is something called, and I'm not making this up, quote, grim age. It estimates an epigenetic clock by combining many biomarkers, and previous studies have shown that these biomarker index measures and predicts biological age and mortality. The authors recruited more than 400 volunteers in the New Haven area to assess the impact of cumulative stress and then stress physiology and resilience on accelerated aging. And the study is super complicated and some of the p-values are barely significant, but here are the 3 main findings. First, cumulative stress was associated with the acceleration of this grim age and stress-related physiologic measures of, like, say, adrenal sensitivity and insulin resistance. Second main finding, psychological resilience factors moderated the association between stress and aging, such that with worse regulation of emotions, there was greater stress-related acceleration. And with stronger regulation of emotions, any significant effect on stress or grim age was prevented. And the third finding was that self-control moderated the relationship between stress and insulin resistance, with high self-control blunting this relationship. And in the final model, in those with poor emotion regulation, cumulative stress continued to predict additional grim age acceleration, even when demographic, physiologic, and behavioral covariates were accounted for. Now, I can't dissect this sort of study like I can a cardiology study. The findings do fit my priors, so I could be totally deceived here. But still, these results make us think a lot about the non-procedural, non-pharmacological factors that could help us help our patients. And I know you just can't tell people to reduce their stress or change their personality type, but we can recognize the importance of lifestyle, life choices, and coping techniques in health. The study doesn't tell us what to do, but it does remind us that health stems from far more than pills and procedures. Third topic today is related, anxiety and neuroticism and the association with cardiac risk. The Journal of the American Heart Association published a similar related type of observational study, And this is more of a typical cardiology study. It was a longitudinal study, so followed over time, about 1,500 men. The authors, first author, Louina Lin, studied the association between two anxiety facets, neuroticism and worry, with cardiometabolic risk factors. Now, I had no idea that one can measure neuroticism and worry, but I guess you can with something called a ISNC personality inventory short form. And again, I'm not familiar with this, so I can't dissect the details of this. But I do know that longitudinal studies let researchers measure variables at baseline and over time, then make correlations between these variables. It's called regression, but it's basically finding correlations and associations between variables. The main results of this paper were that higher neuroticism and worry levels were associated with elevated cardiometabolic risk factors across time, and with 13% and 10% greater risk, respectively, of having greater than 6 high-risk cardiometabolic markers. And this was after adjustment for potential confounders. So the authors conclude that anxious individuals may experience deteriorations in cardiometabolic health earlier in life and remain on a stable trajectory of heightened risk into older ages. So again, we should not make any causal assumptions that being neurotic and anxious leads to cardiac disease via higher cardiometabolic risks. And again, you just can't tell people to be less anxious or neurotic. But the point here is similar. It's about stress, and how one handles stress is likely very relevant to vascular health, and as clinicians, we would do well to not ignore it. Now, speaking of anxiety, one thing that absolutely, positively drives me bananas is when clinicians, colleagues, contribute to neuroticism, anxiety with our words or actions. So much of what a clinical electrophysiologist does is remove fear and anxiety. People have plenty of things in their lives that lead to anxiety. A doctor's or clinician's words should not be one of them. The thing that depresses me most about our profession is when we enhance fear and anxiety of people we are charged with helping. Now, it took me a long time in my career to be cognizant of how much damage we can do in our messagings. And I'm still no bedside guru. I'm far from perfect. But a little voice in my brain goes off every time I begin to explain an issue. It says, John, how are you going to arrange your words and posture so as to heal, not harm? Well, to all my young listeners out there, please always be super careful with your words. You have immense power to both heal and harm. Okay, final topic today is TAVR. The journal JACC Interventions has published a report from the Burn TAVR Registry from 2012 to 2019, and the purpose of this paper was to investigate the rates, predictors, and prognostic impact of technical success in patients undergoing TAVR. Now, there were about 1,600 patients in the report, and they were stratified according to something called the VARC-3 VARC3 technical success. VARC3 stands for Valve Academic Research Consortium 3. And it requires 4 things for technical success. 1, freedom from death. 2, successful access, delivery of the device, and retrieval of the delivery system. 3rd, correct positioning of the prosthetic heart valve into the proper anatomic location. 4, freedom from surgery or intervention related to the device or to excess or cardiac structural complication. Now, to me, I'm an outside observer. I'm a neutral Martian when it comes to TAVR. These all seem extremely reasonable. But here's the thing that surprises me in this paper, the one finding. 1 in 10 patients, 11.6%, undergoing TAVR with contemporary devices and techniques experience technical failure, according to this research definition. This is incredibly worrisome because patients not achieving success had significantly higher rates of CV death and stroke. Now, I realized it's 2022 and the study only went through 2019, and maybe we've had this miraculous improvement in techniques in the last 2 years, but still, I suspect that the surgical failure rate over this time was nowhere near 1 in 10. So I see this sobering finding, and it further reiterates my contention about TAVR. It has been a fantastic intervention. I love TAVR, and I love it especially for patients in whom surgical risk is intermediate or high, and for these patients it can be unbelievable. But when we start doing this procedure with a 1 in 10 technical failure rate to lower risk patients, registry data like this really needs to be taken seriously. So perhaps things have improved over the past 2 years. If it has, let me know if I'm off base here. But it seems like when it comes to replacing aortic valves in patients who could be done surgically at low risk, we would want ironclad evidence that TAVR is just as safe and efficacious. And I say not just in trials, because those are the best case scenarios. I'd say safe and efficacious in registry real-world data. So that's it for this week in cardiology. As always, I'm grateful that you listened, and thank you. And remember, friends, if you like this podcast, it really helps to give us a rating, write us a review. Even a sentence or two helps. Leave us a comment on the heart.org Medscape Cardiology webpage. There's been a few more comments, and these have been great, so thank you. Even if you disagree, please let me know. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.